Good afternoon. Welcome to today's Grand Rounds. Please remember to sign the attendance record, and then also please remember to fill out the program evaluations and give us any ideas that you might have in regards to future topics or future speakers. Today our speaker is Dr. Shane Hopkins. Dr. Hopkins has been a generous contributor at Grand Rounds. He's provided us with a couple of really good Grand Rounds in the past. He's a radiation oncologist and a member of the radiation oncology departments here at Mary Greeley and at McFarland. And I know that he treats patients with prostate cancer and breast cancer and lung cancer, but today he's going to give us an update on several uses for radiation therapy that we might not be aware of. So please join me in welcoming Dr. Hopkins.
Thank you. Well, thank you very much for the opportunity from the CME committee for me to come and visit with you again. I gave a talk not too long ago sharing with Dr. Deitch about prostate cancer, and I'm just curious to know how many of the people who are in attendance today were at that talk? A few months ago, okay. So a handful of people. One of the reasons I'm asking is because some of the same slides are in this talk. Just because I feel like some of the concepts of radiation are unfamiliar to people. And I want to make sure that you understand exactly what we do in our department. I feel like we're in our own little isolated corner of the hospital, and so much of what we do is a little bit inexplicable to people who aren't familiar with it. And so I want to go over that again and show you just kind of some background information about how the radiation works. So the topic today is a dozen uses for medical radiation you probably never realized. And I just figured I'd just throw up on the board the answer right on the second slide. So here's some uses for radiation that a lot of people may not realize. Now this is a historic list. These are things that were treated that we wouldn't treat anymore, things that have been treated that had horrific side effects that were not anticipated, or secondary cancers or problems throughout the rest of the patient's lives. It also includes things that we do still treat. And so part of the reason for today is to point out to you, radiation is a fundamentally toxic treatment. And we have to make the decision about when to use it, that it's going to actually benefit the patient on balance, and how we make that decision. And how it's a team effort to make that decision in terms of referring providers, calling and speaking with radiation oncologists, so that together we can decide what's going to be most of service to an individual patient. I want to run through the objectives that were distributed in the announcements about this talk, and just answer these questions right up front. First off, describe when to refer patients with a lung tumor for evaluation by radiation oncologists. I think the answer to this question I just want to get out there right now is whenever there is a reasonable possibility the patient will need radiation or could benefit from radiation, it's good to get an opinion early on, so that you're being managed by the entire interdisciplinary team. Our standard referral pathway is that it goes through pulmonology and the surgeons and you know, the radiologist, and that's the initial team that's going to be diagnosing a lung cancer, and the pathologist and that group of people. So the radiation oncologist is nowhere on that list. And so we don't see the patients until usually later in the process. But there are occasions when radiation is a great option for a patient because they're not a good candidate for surgery. And it seems that a lot of times we end up seeing the patient after some of those decisions have already been made, and sometimes opportunities lost or bridges burned because this happened or that happened, and now they can't get radiation anymore. And if we'd only had this conversation a little while ago, maybe things would be different. So how do you know when they're a good candidate for radiation, or when that may be a possibility? The NCCN guidelines. That's my recommendation to you. It's an easy, available thing. Anyone can sign in there and look and see what they have to say, and I'm going to go over that a little bit later. Second objective, describe non-oncologic conditions that may be treated with radiation. I showed you that big list there. Here's 6 examples of things that we still occasionally treat with radiation that are not cancer related, but we feel that the benefits outweigh the risks of the toxicity of the radiation, and I'll talk to you a little bit about why that is. They include gynecomastia, keloids, arteriovenous malformations, vestibular schwannomas or acoustic neuromas, meningioma, and heterotopic ossification prophylaxis, which of course is abnormal bone growth after there's trauma to the muscles, usually around hip surgery and that sort of thing. So this is the short list, I guess, of things that we don't necessarily see people very often. Not that we necessarily need to see people very often, but I just want to make sure people know that we can potentially help in situations such as these. And then the last objective, which apparently I just crashed it. Hold on a second. Describe uses for radiation other than for cure or pain relief in oncologic patients. So I'll tell you right now, radiation is also useful for stopping bleeding. It is useful for decompressing if there is a tumor mass that's pushing on any particular, it can be a superior vena cava syndrome, it may be on the airway, it may be on the bladder or the rectum or the bowels, or in whatever way. If it's compressive, that's a palliative treatment that radiation is useful for that often we may not get considered for. I think people know spinal cord compression, that's one that people send us someone right away. We can help in that circumstance. And then there's also other things like hypercalcemia or other paraneoplastic syndromes where, coagulopathy issues and that sort of thing, where there's an actual medical issue that's being caused by a tumor, and debulking the tumor with radiation allows us to sort of relieve some of that medical issue. And it's a little bit counterintuitive, not something we see patients for very frequently, but that's another thing I just wanted to mention to you today. So those are the 3 objectives, and I tried to give you the answer now. I'll give you the answer, the long version now for the rest of the talk, answer some questions, and hopefully that answers some of those questions. So today, first off, I want to talk about radiation, the term itself, and some of the science behind radiation, and why we do what we do, how we do it, some of the therapeutic techniques to use radiation, the types of machines that we use, and the technologies and the science that goes behind it, and then a discussion of the data for some of those unfamiliar uses inside and outside oncology, including the vestibular Schwannoma OVM. So that's where we're going to go. To start off, I got this slide with a quote from Marie Curie. "Nothing in life is to be feared, it is only to be understood. Now is the time to understand more so that we may fear less." And when I've showed this slide before, someone pointed out, yeah, she died from her radiation. Maybe she should have feared a little bit more and been a little less inquisitive, right? Stayed away from the stuff. So, like I said before, radiation is fundamentally toxic. We understand this now, and unfortunately, we didn't always understand this for medical radiation. There was really aggressive efforts to use medical radiation for all sorts of things. It was just thought to be the fountain of youth. I mean, you could get rid of wrinkles. You could do cosmetic things. You could use it on children for tinea. You could use it for acne. You can use it for, and then of course you find out later in life there's serious consequences of using high doses of radiation in young children, and even in middle-aged folks who have decades left, because you get secondary cancers, you get other problems such as that. But as we understand that more, as we have an awareness of the risks, of the possibility of adverse consequences, then we have a better understanding of how to put that on the scales against the benefits so that we have an accurate risk-benefit analysis and we can make a decision about when to use the radiation. So I want to show you a little bit more about radiation. Of course, this is just a little atomic model here. We use electrons for radiation treatments, a beam of electrons. We use neutron beams. We use proton beams. Neutrons and protons are not done at this center. There's only a couple places neutrons in the entire country. One of them is Chicago, and so it is locally here. It's very good for certain things, but there's a different property when you have a neutron beam. Obviously, neutrons do not have a charge, and so they have different properties than protons that are of a similar size, but they don't cause the ionizations through the same mechanism that protons do. When you send a high-energy beam of protons whizzing into the tissues, it disrupts the electrons and dislodges them from atoms because of the charge in a different way than neutrons. So they all have different characteristics and properties, and that's important to understand. But most of the time when we talk about radiation, we're talking about light. So light can be of many different kinds. This is the spectrum. You may recognize it from your middle school textbook, right? So this is something you've seen. Visible light is in the center, but you've got microwaves and radio waves and infrared light, what we use. So if you talk about radiation and you're talking about visible light, no one gets upset. But usually the implication for radiation is we're talking about high energy light that can be very dangerous. And so, people imagine Chernobyl and mushroom clouds and the little, buzzing figure with the radiation symbol and all the fear that instills in people, mainly because of misunderstanding. And so it's important to understand, yes, this is all light. This is all the same physical phenomenon that's going on here, electromagnetic radiation. And it's just a matter of understanding how it interacts with matter at the different energies so that we can use it to actually cure or help patients in various different circumstances. So on the far right end, gamma rays, these are produced by radioactive decay. And in certain circumstances, we put the radiation source right inside the patient's body, sometimes with an injection, sometimes with a seed pellet that gives off radiation. There are lots of different ways to do that. The X-rays that we use in our department are several orders of magnitude higher in energy than the X-rays that are used in the diagnostic radiology, usually, the ones that we use most often. And so they have different properties. They react with the tissues in a different way. So we get these fantastic diagnostic images because of the photoelectric effect that when the light interacts with the tissues, and it's relying on density. It's very heavily relying on the density of the material. But when we get up to the higher energy that we use in our department, it interacts by the Compton effect, which means that it's more based on the water content of the tissues, and it's a different interaction. And so it's not something that people need to be afraid of. You just need to understand more about why we use that and what it's for. So these are four different dose curves for different kinds of radiation treatments that we provide to people. And I just wanted to put this in here so you can see how one radiation treatment is not the same as another radiation treatment. Just like you can't say, well, I had chemo. Well, what kind of chemo? Because some of them are pills, some of them are injections, some of them will lay you out for weeks and weeks, some of them will, you won't even know that you had it. So if you look here, first off, the one that I would say probably we use the most, or you would think about the most, would be the closest to this in the 4 megavolt. So you can see there's a little shoulder on the very initial part of the curve. So the x-axis is depth. You don't get the highest dose right on the skin, but just a little bit below the surface of the skin. And then it steadily deposits its dose as it's going through the tissues, and it's attenuated. But a typical person from one side of their body to the other side of the body, let's say you're going through their chest, probably 20 centimeters, something in that neighborhood. So you can see there's still X-rays left coming out the other side when we do this, but they're significantly attenuated. They've lost a lot of the energy they've deposited along the way. And so most of the energy was in the superficial area. So if we want to get the depth penetration a little bit higher, we increase the energy of the X-rays. So the 20 MeV X-rays up here are the green dotted line. You can see that the maximum dose is a few centimeters deep now, not just right underneath the surface. And indeed, the skin surface is less than half of the maximum dose there. That's very useful. We can actually use these this particular energy so that we are able to decrease the toxicity of the skin. So if a patient is getting a treatment in the pelvis, like to the prostate or for a gynecologic malignancy, if we use this, they're going to have essentially no skin toxicity. It's subclinical. There's some dose deposited there, but it's not enough that it's really going to bother them. And that's very useful. So we can use that particular energy to get the dose as deep as we want it. The blue line and the green line are X-rays, but the purple is electrons and the red is protons. So now we're talking about particle therapy. The purple is very shallow. So you can see that all of the dose is attenuated within a couple centimeters on that particular energy. And with the protons, you get this really unusual distribution where most of the dose is deposited all at once in this burst of energy after a certain depth. This is 150 MeV protons, but if we choose a different energy of protons, it ends up giving this peak, this burst of energy at whatever depth we choose. And that's important for being able to deposit the dose exactly where you want it. Now, I know this slide is at a high risk of making everyone glaze over their eyes really early in the talk, but I think it's really crucial because this is key to what you send a patient to a radiation oncologist to help decide, and that is to come up with the appropriate modality that's going to get the dose where we want it while minimizing the dose to the normal tissues. Those organs at risk, it's a science, it's an art. We have a multidisciplinary team that's very good at using all of these tools together to be able to get the dose where we want it to go. So the last thing I just wanted to mention here on the Marie Curie slide is a little bit about the overall orders of magnitude of difference in different radiation exposure and how people hear radiation and they become extremely concerned regardless of the source or the purpose or anything else. As you know, there's scanners in the airport. There's a couple different kinds. One of them is a millimeter wave technology that doesn't involve X-rays, but there is a common type that uses backscatter X-rays. And so this has caused widespread concern about radiation exposure that's caused by these machines, and is that necessary, and how can you be exposing people to radiation without them knowing about it, and that sort of thing. The government said it's safe and we're going to keep doing it, but then a lot of professors have written editorials and letters saying that we don't think it's safe and you should use this other technology. Well, the fact of the matter is that it would take 20,000 scans like this to equal one CT scan in terms of the exposure. And so that's a pretty telling number. You would have to get a scan every single day for your entire life to even remotely come close to like a chest x-ray or something like that. And so it's all a matter of degree. And when we're talking about radiation dose, it's really hard for people to wrap their mind around exactly how much dose is my heart going to get if you're irradiating my breast, or how much dose is my whole body going to get if you're just radiating this tiny little spot on my skin. And so it ends up being pretty complicated. And I apologize that the computer does not apparently like this presentation. It's got a lot of bells and whistles, so. All right. This is a dose response curve. And this is the essence of radiation oncology right here. When we have a patient with a tumor that responds to radiation differently than the normal tissues that surrounds it, we get what's called a therapeutic differential. And we go from the curve on the right to the curve on the left. And this is important because we're trying to minimize normal tissue toxicity while maximizing tumor kill. And so if you just look, I guess let's just look at this sigmoid curve, the blue curve, and it doesn't have any numbers here on the dose axis because it's more of a conceptual thing. But this is how tumors respond. You give a dose and some of the cells die, and then you get to a steep part of the curve where most of the cells will die. It becomes exponential, where once you go up beyond that, you're getting almost nearly all the cells to die. But the normal tissues can repair themselves. Cancer is cancer because it's not working right, and it doesn't have the normal cell mechanisms in place to the same extent that normal tissues do. And so depending on the kind of cancer and depending on the kind of normal tissues that surround it, you get a separation in these curves, and you try to choose a dose point that's going to give you maximum tumor kill and the minimal amount of normal tissue toxicity. And so making the decision about whether this is even possible, because some circumstances you're presented with a situation like this, where the curves are identical. Sometimes they're even reversed. And there's different tricks that we have in our toolbox where we can try to separate those curves even more. And that includes fractionation, where we break it up into daily treatments rather than giving all the dose of radiation in a single time. Sometimes giving medications, giving chemotherapy at the same time increases the therapeutic differential for some cancers. For others, it's not. It doesn't make a difference. It just makes it more toxic for the tissue, the normal tissue and the tumor both simultaneously. And so this is the crux of what radiation is all about. So you have to take that information, take the risks and the benefits, put them all together, and try to make a decision about whether it makes sense to go ahead and proceed with the treatment or not. So stochastic effects are those effects that are caused on a random basis. And there is no minimum threshold dose if you can avoid the risk of a stochastic effect. So a secondary cancer is a stochastic effect. And even the smallest dose of radiation, even that the backscatter X-ray technology in the airport has a risk of causing cancer. But the risk is 1/20,000th of what the risk is if they were to get a CT scan. And so it's really just a matter of understanding the level of risk and how that compares to the level of benefit if the patient is or is not to receive the therapeutic dose of radiation for some clinical purpose. Now in cancer, it's high stakes and it's easy to justify using the radiation, but for benign diseases, it's not as high stakes. And for children, it's It's high stakes in a different way. It's high stakes in terms of toxicity for benign disease because you have a long life expectancy. And for children, it's the same story. Bioequivalent dose. So even though dose is measured scientifically as joules per kilogram, that's gray, if you've heard that term before. A gray of proton dose does not have the same biological effect as a gray of neutron dose or electron dose or high energy photons or low energy photons. Every different characteristic beam of radiation has a different biological effect. And so you have to make some adjustments in terms of what type of radiation is being delivered, and you also have to make some adjustments depending on how much is delivered in a particular setting, because it's an interaction biologically where there's sublethal damage to the cells that can be repaired within a certain period of time if you are doing pulsed radiation. So the point is it gets complicated. That's the point in terms of how to analyze the risks and the benefits. Age and comorbidities. If a patient has scleroderma or xeroderma pigmentosum or something like that that gives them a sensitivity to radiation, that's going to change the equation. You're going to have a lot higher risks for not as much benefit in a circumstance such as that. Deterministic effects are the ones below which you expect not to have an effect. So I know that if I stay below 2 gray, I'm not going to cause cataracts in the eyes. And so that's the deterministic effect. It's not stochastic. I know that if I'm below 2 gray, there's still going to be a chance, however small, of a secondary cancer because that's a stochastic effect. And then parallel versus serial organs, if we do a high ablative dose to a part of the lung and the patient has good lungs, we have redundant lungs. It's a parallel organ, and a small section of the lung being obliterated with that radiation will be subclinical most of the time. So that goes into consideration versus the spinal cord, where no portion of the spinal cord can go above 45 gray in our typical radiation planning without us being extremely concerned, because it only takes one cross-section of the spinal cord to go over the tolerated dose before you're paralyzed and it's irreversible and it's a serial organ. So this is the review part from my last talk. I wanted to tell you a little bit about the actual technology behind the radiation that we deliver, some of the terminology that's in there. The conformal radiation just means that we used to put on big square fields, large splashes of radiation going all over the place because that's the technology we had available. And so you put marks on the outside of the body, you used bony landmarks to try to assess where the tumor was on the inside, and then you went for it. Well, then we came up with 3D conformal radiation. It's based on CT scans most of the time, and we can be much more precise. We can shape the beam so that it adjusts exactly where we want it to go. And this is what the modern era of radiation is based on. Now, the more recent fancy technology is inverse plan, where you put parameters into the computer, and it will try to achieve certain goals by shaping the beam in all sorts of fancy ways. This is what the beam shaper looks like. It's called a multi-leaf collimator. And what it does, these leaves will slide in and out while the beam is on, which changes the shape of the exposure over time. And this on the right is a film that was exposed using IMRT so that you can get the dose exactly where you want it to go. So you set up the gantry so that the radiation machine is pointing a particular direction, and then turn on the beam, and it delivers a modulated dose with a gradient, however you want it to be, and then the gantry moves. IMRT means that it's a step and shoot. There's isolated locations where the gantry stops and delivers the radiation dose, and then it goes to the next location, maybe 9 times. But the new one is called VMAT, and that is volumetric modulated radiation. I got to go back to the right screen here. So volumetric modulated arc therapy, and that's where the gantry is traveling the entire time, and the leaves are moving, the dose rate changes, there are a lot of variables in the machine, they're all changing at the same time. It becomes very computer dependent and very technology intensive. And that's why we have a fantastic physics department to make sure that all of this is delivering the kind of radiation dose to where we think it is and according to the dose and distribution that we're planning on. This is the linear accelerator just down the hallway right here. our very own TrueBeam. And this is a mock-up, a little CGI demonstration of exactly how it works. I put this in here just so you can see how the moving parts work. We call that the couch that the patient is lying on. And then there's an onboard imager. That's the thing that just swung out from the side that looks like arms coming out. So it's actually taking a CT scan as it turns around the patient. The MLC, you can't really make out too much, but inside the head of the gantry right here, that's where that leaf device I just showed you the video of is that changes the beam. Along the top of this is a waveguide where we accelerate electrons that then smash into a tungsten target before they turn into a spray of radiation coming down here that gets shaped by the multi-wave collimator. This particular movie is demonstrating onboard image guidance, and so it just took a three-dimensional image of the patient's prostate, allowing the therapist to nudge the patient into position so that the prostate is right in the center of the beam. As you can imagine, the prostate in particular is right between the bladder and the rectum, which are going to change in their size and shape throughout the day depending on when you have used the bathroom. And so this is a way to make sure that the target is in the center of the beam, because we can't necessarily rely on surrogate markers on the skin. Correct, and that's new. So that's just in the last year we've started the volumetric, the VMAT, and that allows the beam intensity, or actually the dose rate, to change. The energy of the beam stays the same. There's small variations based on the technical makeup of the machine, but there is a device that measures the output of the machine as it's doing the treatment, and will change it on the fly to make sure that it's delivering consistently according to the way that the physicists calibrated the machine and set it up to appropriately deliver the dose. But all of these variables can now change during the treatment itself, and it's pretty impressive technology. Proton therapy, very briefly, up and coming, very expensive. The benefit is it allows you a tighter dose gradient. You're able to use that Bragg peak. Remember the one that had the spike in the curve when we were looking at the dose depth curve? And that way it doesn't necessarily have exit dose. And so you get a little bit sharper gradient at the edge of your target, and that translates to less dose going to normal tissues, which translates to less toxicity in certain circumstances, especially for children. We're going to be building one here in Iowa in the next little while. These are examples of external beam radiation where the source of the radiation is outside the patient's body. That's 99% of what we do over there. But we also do brachytherapy. And brachytherapy is putting the source of the radiation inside the patient's body. There's various ways of doing this, and there are lots of different kinds of sources of radiation. One of the sources of radiation is when you buy permanent seed implants. We don't do that very often, but that has historically been an important part of the practice of radiation oncology. What we do more often now is afterloading. So we have a robot with an iridium source on the tip of a wire. It's welded on the wire, and then the robot's able to place that into the patient after we get everything set up. And this is for prostate cancer, for gynecologic cancers, for interstitial therapy, where we can put the needle through some tissues wherever we need the radiation to go. And then everyone steps out of the room except the patient, and then the robot will put the radiation source right into the middle of the business part of where we're trying to get the dose. And that allows us to decrease the integral dose, the dose that's outside of the target area. And that's very helpful. And in fact, we're starting to do this now for prostate cancer. And that's something that, it was an old school treatment for prostate cancer. It kind of went out of favor because it's messy, it involves needles, it's interventional. Radiation oncologists, kind of just do beam therapy without a lot of surgical things. But it turns out it's better. I mean, the bottom line is we're getting some data now that looks like combined modality therapy is better for high risk and intermediate risk prostate cancer. You can use it as monotherapy in low risk patients. And so we are now offering this for prostate cancer patients, and I think that's something useful for you to know about. By doing it this way rather than the old school way of putting in seeds, it's prospectively planned, which means it's a higher quality, and we avoid the errors that got a lot of bad press in the last few years. 3 or 4 years ago, there were some really bad articles from the New York Times highlighting a gentleman at Pennsylvania who was doing bad implants, and so this avoids that by doing prospective planning. Okay, so these are examples of definitive radiation, but there's also palliative radiation, of course, and we're going to talk about that in some detail here. external beam. I have this paper here that talks about how we treat bone mets in a single fraction rather than in numerous fractions. And this is important because I think sometimes people are reluctant to send patients to radiation because they think, oh, that's going to be coming in there every single day for weeks. I don't think this patient's going to tolerate that. And so we just won't bother sending them over. We'll figure out something else. We'll just give them some fentanyl and hope for the best. Well, we can do a single fraction that's very helpful for bone pain, and we're doing this quite a bit, and it actually has worked really well. Unsealed sources, this is also something just FDA approved in the last little while, is the new radium Figo treatment for prostate cancer in the bone. These are calcium analogs, so you can see how it's in the same column on the periodic table. Radiation is a part of the overall cancer care, including chemotherapy and surgery. So these are your primary interventions for cancer patients. And so people usually think of radiation in terms of oncology, and that's why I'm a radiation oncologist. Most of my training was focused on cancer-related care. But part of the point of this talk is to talk about this sort of off-to-the-side use of radiation for non-oncologic issues. So now I want to get into some of the data for some of these other uses of radiation that you may not know as much about. So gynecomastia, this is where you have enlargement of the breast tissue in men, and it can be painful and make the breast tender. It can be sporadic. It happens in adolescence quite frequently, and obviously we don't do radiation in adolescence for this because of the toxicity and the side effects of that. But it happens quite often as a side effect of androgen deprivation therapy. And so if patients are getting Casodex as part of their prostate cancer, they may be at a really high risk of having gynecomastia. And this is an effective treatment that allows us to prevent that from happening. And we don't usually give it preventively, even though it is quite a frequent side effect. Up to about 70% of these gentlemen who got Casodex as the main part of their hormone therapy had this. But when we do hormone therapy here, most of the time it involves not so much Casodex as it does an LHRH agonist that is going to work through a different pathway to suppress testosterone, and so it's not necessarily as much of an issue. So you're going to see less gynecomastia. So we don't do it prophylactically, and that's appropriate. I'm just going to run through here a little bit of the science of this. So testosterone levels are accompanied by increases in estrogens. Basically, when you're on anti-testosterone prostate cancer therapies, the estrogens induce proliferation of the male breast glandular tissue, and it can be irreversible in terms of some fibrosis, so that's one reason for the prevention. Prophylactic radiation is effective. A single electron beam, so this is an on-fossil electron treatment. We usually put a margin of about 5 centimeters around the nipple with an electron treatment. It doesn't go very deep. So you remember the dose curves that I had up there, the one that was the narrowest, that's the one we use for this. And so it's not going deep down into the heart or into the lungs. It's completely deposited within the first superficial part of this so that it treats the breast tissue only. Multiple fractionation regimens are used. It turns out my partner, Dr. Joe Rose, just, I believe, treated someone recently, used, I believe, 3 fractions for this, and that's what I would normally favor. Prophylactic hormonal therapies have also shown to be efficacious for this. So tamoxifen. So if you had the opportunity to get radiation or tamoxifen for this, I would take the tamoxifen. It's been shown to be as effective, maybe it's actually shown to be more effective, I should say. And it's cheaper and it's easier and it's a great drug. So if they're eligible, that's a good way to go. Not everyone's eligible though. When we actually compared radiation to tamoxifen, this is what we found out. So this is an Italian randomized trial. Arm 1 didn't get any kind of adjuvant therapy. They just got the bicalutamide, and 70% of them, essentially 69%, got gynecomastia. Tamoxifen in the second arm, only 8% got gynecomastia, so that's a winner. And then in the third arm, radiation 12 gray times 1, so that wouldn't be my favorite fractionation, but tamoxifen should really have been 20 milligrams also. That's a more effective dose. But in the radiation arm, they got 34% gynecomastia. So tamoxifen is a better option, and so it's no small wonder that we don't see very many patients receiving radiation for this for multiple reasons. But it is an option for those who can't get tamoxifen for some reason or otherwise are having painful gynecomastia. Keloids. So this is something that may not see a whole ton of around here, but excess scar tissue that recurs very frequently after surgery alone in the vast majority of cases. And you see this reduced with intralesional steroids, it's reduced to half. But that's still a pretty bad frequent recurrence rate if there's something that you can do to decrease that even more. So radiation, it turns out, reduces the recurrence rate significantly more. Some of the modalities that have been tried to treat keloids include surgery, radiation, pressure therapy, cryotherapy, injection of steroids, interferon, chemo, topical silicone, pulse dye laser. So there's lots of different things that have been tried. There's no one perfect solution for this, but surgery alone, not that great. Oops, I hit the wrong one. Post-op radiation. Success rate, 75 to 90% within 10-year follow-up. There are some studies that are kind of one-off that disagree with that. And so I guess you have to take all of the data in the clinical literature as the best you can to try and figure it out, but usually works pretty well. 3 to 4 fractions, 3 to 4 gray each. And they did find that dose escalation is helpful. You're going to be more successful if you get a little higher dose in there. But overall, it's a low dose. And so overall, you're not going to expect a large amount of toxicity. You're not going to accept a large amount of risk associated with that. And it's a reasonable way to decrease recurrence, especially for someone who has a history of recurrent keloids, because the more you go back and try to take them off, the more there's just exaggerated scarring, and it just gets larger and larger, and it faces and distorts the tissue in that area. And at some point, you just have to stop. We can use a very superficial kind of radiation for this, and so again, not too high a dose and not very penetrating. It should be very well tolerated. Arteriovenous malformations are abnormal communications between arteries and veins in the brain. So these can bleed and cause strokes in folks, and they're fairly common. Annual risk of hemorrhage is 2 to 6% per some papers, with associated fatality rate is pretty significant. And so this is an issue. So how do you treat these? Well, there's lots of different ways. Primary treatment approach is surgical resection, and stereotactic radiation is kind of a backup option. So if surgery is not really going to work out because the patient is not a surgical candidate, stereotactic radiation is the one where we're very careful about shaping the beam so that it goes exactly where we want it to and has a very steep dose gradient, stay off of the organs at risk. And so obviously surgical inaccessibility, high morbidity due to eloquent location or large size, medically inoperable. These are patients that are good options for receiving this. Probability or obliteration is about 80% for smaller lesions and depends on dose. So one paper that looked at this from the University of Florida showed that with a mean dose of about 15 gray to the AVM, success was dependent on the size, 81% for the very small ones, 89, and then 69 if it was quite large, greater than 10 cc's. Another paper here from Pittsburgh showed that they got a 72% success rate when they measured it by complete obliteration. But remember, complete obliteration is not necessarily the most meaningful clinical endpoint, but it is the one that's potentially easiest to measure. So very few patients were treated with doses outside of the range of 15 to 25 gray, and so this is a reasonable treatment option as well. So arteriovenous malformation, not necessarily something you see a ton of, but that is something that we can help with radiation. Vestibular Schwannoma, this is also known as acoustic neuroma, and this is a benign mass arising from Schwann cells, causing hearing loss. You can get it on lots of different nerves, and here's kind of an explanation of the different distribution that you can see it, the kind of symptoms that are caused on the different nerves, but the ones that we see and the ones that would be most amenable to radiation is along the acoustic nerve, and that's where you're seeing a lot of hearing loss as the main symptom here. And so you can see this is very intensely enhancing right through the internal auditory canal that's contoured on this slice for radiosurgery. These can be treated by surgery. When we do a comparison, there's going to be a paper coming up on the next slide. I got a slide ahead. So this is Thomas Jefferson looking at how we do our dose for this using radiation, and there's 2 different doses, and basically they said the lower dose is just as good, has less toxicity. This is the one I was looking for. This compares surgery to gamma knife surgery or radiosurgery. And actually, let me take a moment. So frequently asked question, what is a gamma knife or a cyber knife or a true beam? What's the difference between all these different machines? Well, they do have different technologies and different ways of using radiation. The gamma knife uses cobalt and has an extremely tight gradient for radiosurgery. The cyber knife uses a linear accelerator on a robotic arm, so it can use it around and has a greater movement of freedom than a linear accelerator like we have here. Does not have as good of a gradient as gamma knife, but still very good gradient for radiosurgery. And the linear accelerator is the multi-purpose machine that we have that is still able to do stereotactic radiosurgery with an excellent gradient, but it just works through a different technology. And so they're brand names of the same technology. So we're talking about stereotactic radiosurgery, and there are some cases where, yes, the brand makes a difference, but most of the time it doesn't. In this particular case, these were patients treated with gamma knife, and they found that the surgery caused more facial nerve motor disturbance, and the radiation preserved hearing more often, and had decreased hospital stay and decreased days missed from work compared to surgery for treating this particular vestibular schwannoma. So this is something that I've not seen much of, but something that I think we certainly have the technology to do an excellent job treating these. Meningioma. So it's something I think everyone's probably somewhat familiar with. This is extremely common. You see 13 to 26% of intracranial tumors, 6 per 100,000. It's about twice as common in women as it is in men. One of the risk factors is having received prior radiation, especially if someone was a kid and they got radiated for tinea capitis or something like that back before we knew better. Now they have meningiomas all over the place. Neurofibromatosis, breast cancer patients for whatever reason. Well, actually, because of the hormone aspects of that, that's exactly the reason. So meningiomas. So this is kind of a picture of what the meningioma looks like. In particular, a cavernous sinus meningioma. You can see it's got dural tails. This is going right along. You can see kind of where it's tracking right along there. You can see a little dural tail there. And so this can be treated with conservative management if it's really small, or definitive surgery. Sometimes it's subtotal resection at surgery, and so there's a little bit left over, and you were concerned because it was high grade or because of the location, and so you want to do adjuvant radiation afterwards. And sometimes it's just radiation by itself. So radiosurgery is a legitimate thing for that. The treatment dose is 54 gray for grade 1 and 60 gray for grade 2 and 3. And so those are just based on the WHO classification. So cavernous sinus meningioma is a scenario where surgery is going to be very difficult. And so radiation is going to be an excellent option to decrease the morbidity they would have to go through if they were to have surgery done. And we have done numerous of the, well, not numerous, I'd say a half dozen of these over the last couple of years. And so, well, maybe not even that many. But we have had several patients that have received cavernous sinus meningioma treatment with radiosurgery. So post-op radiation, here's a retrospective analysis from the University of California at San Francisco where they had 108 atypical meningiomas and found the recurrence rate was 28%, no recurrence with the 8 patients who received adjuvant RT. So this is why it's helpful after surgery to receive radiation if there was a subtotal or a gross total resection, but it's a high grade, or it's subtotal resection without the high grade. So here's another trial from Mayo Clinic, this one from 2003. This is one where they're showing that there was no statistical difference in terms of the radiosurgery when you look at progression-free survival. 100% versus 96% respectively when you're comparing the surgery to the stereotactic radiation. All right, next up, heterotopic ossification prophylaxis. In case you're keeping score, this puts us at a half dozen. So, we're trying to get to the dozen mark. We're not going to get there. We're just going to, this is the last one of these. And then I'm going to talk to you about palliative uses of radiation for oncologic patients and a little bit more about SBRT for lung. But heterotopic ossification prophylaxis is helpful because we've done several of these recently and it's been nice. I think that we can be really useful in this particular regard, and I want to explain to you why and how. So heterotopic ossification, what does that mean? It's dystrophic calcification in the muscle. It can cause pain. It's precipitated by fracture or other tissue insults. So sometimes young people just get injured in sports and they get some heterotopic bone. It just grows in the muscles because of that injury. Hip is the most common location, but it can also be in the knees or the elbows or other parts of the body. So here's the risk factors. The biggest risk factor is if you had heterotopic ossification before, you're the most likely person to have it again. Being male, for whatever reason, it's much more common in men. Hypertrophic osteoarthritis, et cetera, et cetera, et cetera. So you see there's a number of clinical and surgical risk factors. Dr. Wormy has been sending patients to me who are young guys with sports injuries who have never had a hip replacement. They don't need a hip replacement, but he had to go in and do a scope because of some type of a tear or lesion there, and there was real aggressive manipulation of the hip tissues, and so there was air in the muscle and there was lots of manipulation, and he knows from experience that this is a high-risk subgroup of these young men, and so he sent them for heterotopic ossification prophylaxis. Well, it turns out you do have options for this. So you can do this you can do prophylaxis to try and stop the heterotopic ossifications from happening with Nsaids. So you can give a medication for this, or you can do the radiation. And the timing of the radiation is important. But let's first talk about Nsaids. This is what I think is used as kind of the default. It's cheaper, it's straightforward, it's easy to wrap your mind around and comprehend exactly what it is and how it works. Unfortunately, there's more to it than that. It's weeks of getting a medication that may have side effects that causes poor compliance and can cause GI bleeding in a set of patients who already may be on blood thinners because they just had hip surgery and they're immobile. And it increases the rate of bone non-union following fracture, so that can cause complications from your hip surgery. So it's got its pluses and its minuses. Radiation, here's a slide that you can read very clearly, I'm sure, that talks about the different doses for a single fraction of radiation. We've tried lots of different things, but ultimately we've come down on a very reasonable dose that doesn't have essentially any acute toxicity, but obviously you always have those late effects that you have to be worried about late in life. So it's a very manageable dose, single fraction of radiation given within 72 hours after you finish treatment. When you compare the radiation to the Nsaids, meta-analysis showed that radiation was twice as effective, or nearly twice as effective. But the absolute difference, the absolute benefit in this meta-analysis was small. It was about 2%. And so, it's a user's choice. I know that there are folks who prefer the Nsaids and there are folks who prefer the radiation, and to each his own. I just want to make sure that people are aware that is a possible use for this, and we have been very successful. We've used this here in our medical center very successfully. Heterotopic ossification prophylaxis. So I'm zooming back out, non-oncologic radiation, that's where we've been. Now we're going back over to the oncologic radiation because I want to tell you a little bit more about palliative care. So palliative bleeding. Pretty much these slides say, they don't go into the literature very much, so they say what I've already just said, and that is we can stop bleeding, especially for gynecologic patients who are having a lot of vaginal bleeding because of a tumor. It's a palliative treatment. You can stop the bleeding by doing even a single fraction of radiation. If you do 4 gray or 5 gray in a single fraction, that's helpful, but a lot of times we do 2 weeks of radiation. That's the typical palliation. But just depending on what their performance status is like, we can certainly do fewer fractions, and we try to work that out with a referring provider, with primary care providers, depending on the patient's performance status. You get a little bit more durable response when you fractionate it out somewhat, and so there's competing interests again. Second thing, palliate mass effect. This is what we were talking about before. You can get dyspnea because there's a small cell cancer in your lung that's just compressing the airway down. We can do palliation using endobronchial brachytherapy, where we actually put a tube down into the bronchus and then feed that iridium source down with our high dose rate brachytherapy machine. That's been very successful in opening up the airway and palliating that. Dysphagia, you can do the same thing. You put the tube down through the throat into the esophagus and shrink down an esophageal tumor so that there's better swallowing. I actually have 2 esophageal patients right now who both started about the same time. One has had an enormous improvement in his swallowing after receiving the radiation. He's able to get food down much, much better. So it was very effective. We're giving him a definitive dose, but for the purpose of palliation, it was very effective. The other one, who started just about the same time, has just the same kind of tumor in the same area, same chemo, everything else, doesn't seem to really be shrinking it down that much. So still requires tube feedings and the rest of that. So, it's individual per patient, but we certainly are able to attempt that and have a beneficial effect in many patients. Palliative paraneoplastic syndromes, hypercalcemia, I mentioned that before. That's pretty much all I have to say about that. So, last up, stereotactic body radiation therapy. This is also known as stereotactic ablative therapy. And I just wanted to talk to you about how we use the NCCN guidelines. I use them every day. This helps me to know exactly how patients should be managed and treated. And when we decide to depart from the guidelines, it's a deliberate decision. I like to know what the guidelines suggest, and then I make my decision to go away from that specifically for whatever reason. But I commend this to you. When you look at this, you can see the staging and the workup is enormous for lung cancer. It goes to all of these different branch points. You go to the second page, and you see that there's stage 1A and stage 1B. Normally, the standard of care in this situation is surgery. But if it turns out the patient is medically inoperable, you see right here in the middle, it says definitive RT, including stereotactic ablative radiotherapy. So it's kind of a little footnote there. It's kind of hard to see. That's helpful to know. What I want you to know about that is that's not something that every patient qualifies for. So they can't get it if they've already had surgery in that area, most likely. They can't get it if they have nodal metastases. They can't get it if they've had, if it's too close to critical structures like the spinal cord. So there's a lot of different caveats on that. But if you see this in the NCCN guidelines as an option, it's a great idea to send them over to get an evaluation by a radiation oncologist early on, rather than waiting until later, so that we can all be on board and use a multidisciplinary approach to that. So this is T1B, which is the same thing. It includes radiation if the patient is medically inoperable. So why do we limit it to, and this just shows you don't see any SABR or SBRT on the higher stages. It's all conventionally fractionated radiation. But why would we, I want to tell you a little bit about conventionally fractionated versus SBRT. So on this slide, conventionally fractionated radiation plain doesn't work very well for lung cancer. It's a big disappointment. It's all we've got, so we do it, but it doesn't work very well. So SBRT works much better. Sorry if I'm going to cause a seizure in anyone. This is a little bit flickery here. But several studies have shown that the overall survival is favorable, but it's hard to compare it to controls because we get the sickest patients. The only ones who are on the clinical trials for this are the ones who are not operable to begin with. And so it's really difficult to compare them straight across, but the local control rates are equivalent or even potentially superior to surgery in some series. And so there's a head-to-head trial going on right now looking at surgery versus stereotactic radiation for early operable patients, and we're just going to see if it's as good or not. And it's going to be important because we're doing a lot more CT scans to screen for lung tumors because of the recent trial that showed that when you screen smokers, you're going to save lives. So we may see more of this kind of treatment going on in the future. I'm just going to kind of skip here back. The point of the story is I really commend you to look at the NCCN guidelines and send patients over if it's appropriate for a patient to consider radiation as a part of their the branch that they're going down. This applies for prostate cancer, for lung cancer, for GI cancers. The radiation is often included in the treatment course at some point, and we end up getting it afterwards, and then we can say, oh, it actually would have been better to do radiation before surgery instead of after surgery, but it's too late now because they have already had surgery, and now I'm seeing them for my consultation for the first time. So this is my plea. Probably the people here are not the ones who need to hear that anyway, but I'll just throw that out there. Okay, so I think I've covered pretty much everything I had to cover, and I can answer questions if anyone has any questions. That was a lot of topics.
So what? It's all very impressive. So what's next? And what's out there in the future beyond proton therapy?
Well, that's a great question. I think that there's going to be little offshoots in every direction, using every kind of radiation the best we can in better ways. And one of the things about comparative effectiveness research that was supposed to be a part of the Affordable Care Act and that has a lot of promise to bring down the cost of healthcare in this country is it's not necessarily glamorous. And so I think that some of the best gains in radiation are going to be from things like I mentioned, going back to brachytherapy, even though that's kind of the old school therapy, and it costs a lot less than intensely modulated therapy we're using over here right now, but it's actually turning out is probably better for prostate cancer. If in those patients for whom it's an option, and it's not an option for everyone, and that's why I'm here. That's why I have a job, so I can sort that out and have a consultation with the patient. But I think the next thing is comparative effectiveness. We just have to sort out which of these things work the best and how can we fine tune. And I think there's always going to be incremental improvements in technology that are going to let us be that much fancier with the image guidance and getting the dose where we want it to go and that sort of thing. So it's a great question. I wish I had a more glamorous answer. Many thanks. Appreciate you coming out.